Well, hello, nephron enthusiasts. Welcome to another edition of Question Lab. Tonight we are tackling renal, specifically questions for step one. I'm Jeff, and if you're wondering why I'm so excited about kidneys tonight, well, you're in for a treat. Tonight, I'm thrilled to be bringing back your favorite and mine to guide us through these challenging renal concepts. So Dr. Abraham Titus is with us again. Abraham, would you like to introduce yourself to the crowd?
Great joke there, Jeff. So my name is Abraham Titus. I am a Hematology Oncology Fellow at the University of South Alabama. I've been working with USMLE-Rx for quite a few years now and have helped many students such as yourself score, their goal scores on their step 1, 2, and 3. And I'm excited to go over some nephrology today.
That's great. And, Abraham brings exceptional clinical expertise and all of his teaching and coaching skills. So we're going to be here to really break down some of these complex renal pathways and things that are hopefully clearer and board relevant. So excited to have him back. Tonight we're diving deep into the world of the renal system. You got about 180 liters of your blood getting filtered every day through all these very elegant structures. So, we've got some M1s here. Maybe they're just getting acquainted with or reacquainted with the loop of Henle. We've got some clinical students probably trying to master some of the acid-base disorders. Maybe you're just, again, thinking about step 1, trying to solidify all of those, high yield renal concepts. So that's what tonight's session is all about. We just want to make this, as clear as possible. So one thing you're going to see, and we'll talk about our approach, is that, we want to help clarify some things regarding the kidneys, the nephron, right? And we also want to help you prepare for, whether it's, a CBSE, maybe it's, you've got end of year exams coming up, or again, you're getting ready for step 1. So we'll talk a little bit about the process as we go along. At the end of tonight's session, we are going to have a drawing. So one lucky attendee is going to get a free subscription to RX 360 Plus. And we also have a special offer to share with everybody. Okay. So with that, let's go ahead and get started with question number 1. Okay. So we've got 4 questions tonight. And as you look at the first question, you may notice that something's missing. Well, that is part of our methodology. So first, we cover up the answer choices. Now, might seem counterintuitive, but it's actually a proven technique to prevent you from getting distracted or even dismayed by unfamiliar terms. So, we want to keep your thinking clean and focused, and not let a weird term that you've gotten wrong before, or a concept that you're a little shaky on. We don't want that knocking you off the rails. Step number 2 is we read the lead-in first. So the lead-in is the actual question. It's the last bit here. And this is crucial because, once you have the question down, once you fully understand it, kind of tells you what information that you should be hunting for in the vignette, right? So it's kind of like a map for exploring the scenario. Okay. So let's read the lead in here. Which of the following is the best rationale for reducing this patient's blood pressure with enalapril rather than diltiazem? Okay, so now we understand what the lead-in is. So let's go ahead and read the vignette. A 49-year-old woman comes to her physician's office for follow-up care. She has type 2 diabetes mellitus treated with metformin and has a recent hemoglobin A1C of 8%. Her blood pressure is 138/88, and has been over 130 systolic on 3 consecutive visits, despite weight loss and an appropriate diet. Urinalysis is normal. Her urine albumin is 50 milligrams over 24 hours, and she has started on a new antihypertensive medication. So again, which of the following is the best rationale for reducing this patient's blood pressure with enalapril rather than diltiazem? Think about that as I pass it off to Abraham to break it down.
All right. Thank you, Jeff. So as he mentioned, there are some important steps that we need to take before we approach a question. And just like he said, we want to always read the lead in and then kind of break it down from there. So let's go through, highlight some key important words, and let's try to figure out what this question is really asking us. So I always like to start with the lead in, just like he said, which of the following is the best rationale for reducing the patient's blood pressure with enalapril rather than diltiazem. So there are 2 drugs. You got to think about the mechanism of each one, how they work. And in this situation, they're saying, why would we pick enalapril as opposed to diltiazem? All right. And then I go to the top. I always like to have demographics. So 49-year-old woman is important. It's important that she has diabetes and on metformin. A1C of 8, sure. And then outside of that, she's a little hypertensive. And urine albumin is 50 over 24 hours. And she started on new antihypertensive medication. So she's hypertensive, has a little bit of albumin in the urine. She's got a history of diabetes. And they're asking you, okay, why do we pick enalapril over diltiazem? You got to think it's not only a pharmacology question, there's a physiology question, understanding the real mechanism behind how these drugs work and why it would be a better drug. But let's go through and look at the options. All right, so we got 5 options here. It's going to be typical. I always like to start with E and make my way to A just to kind of, mix things up a little bit, but there's no hard and fast rule about that. So option E, enalapril may normalize albuminuria. Option choice D, enalapril is better for preventing neuropathy. Option choice C, enalapril is better for lowering serum lipids. Option choice B, diltiazem is less effective for lowering blood pressure in type 2 diabetes. Option A, diltiazem increases the lactic acidosis caused by metformin. All right. So take a moment, think about this one. Why would we pick enalapril over diltiazem in this patient, 49-year-old woman with diabetes and urine loss of protein with a history of hypertension? Take a second and let's try to break down and pick the right answers.
Okay, we're going to launch that poll. Let us know what you're thinking. Okay, so looks like just over half of you went with answer choice E, enalapril may normalize albuminuria. And then second place was answer choice D, enalapril being better for preventing neuropathy. And then kind of almost a tie for third place there between answer choices A and B. Okay, very interesting. So let's go ahead and hide the results. And let's share the answer. And the answer is answer choice E. Enalapril may normalize the albuminuria. So nice work, everybody. This was a good way to get started. A lot of you got that one right. But for those of you who didn't, that's okay. That's why we're here. So Abraham is going to walk us through this one. Abraham.
Great job, guys. So a classic question here. You have a diabetic hypertensive patient. Always reach for the ACE or an ARB first. The way you want to think about it is nephroprotective, especially in diabetic nephropathy, where the problem is hyperfiltration and you can have worsening renal function, which can then lead to CKD and end-stage renal disease. To prevent that, your ACE inhibitors and ARBs are really good at that. The idea is that it reduces filtration, therefore it causes less albuminuria. And even the microalbuminuria you may have, it may reverse it or actually halt it. So your go-tos for diabetic hypertensive patients are going to be your ACE inhibitors and ARBs, more particularly because it reduces the hyperfiltration that occurs from diabetes. And that's the big thing to focus on this. Now, if I look at some of the other options here, so there's some, options that are pretty good, maybe convincing options. So neuropathy, it's more of a nephropathy. It doesn't prevent neuropathy. There's no real studies showing that. Of course, controlling blood pressure is going to help reduce chance of stroke and everything like that, but it's not going to be one that we focus on just enalapril being better compared to diltiazem. There's something like that. Enalapril doesn't really have an effect on lipids like that. It has no, it's a neutral effect on lipids. Maybe slightly benefit, but it's not going to be significantly dropping the lipids. For lowering blood pressure, diltiazem and enalapril are both equally effective at lowering blood pressure. So that's not going to be the main reason. And again, diltiazem by itself do not increase risk. Neither do ACE inhibitors of increase of lactic acidosis and metformin. Chronic kidney disease can lead to increased risk for lactic acidosis and metformin, but that's more of a near here nor there. The main focus of this should be enalapril and ACE inhibitors and ARBs are going to be my go-to for diabetic hypertensives, because a different way they can ask this question is why. The reason, especially step one, they'll say to reduce the hyperfiltration or the protein loss in diabetic nephropathy. That's the main way to take away from this. Good job, guys, with this question.
Okay, nice work. So we are off and running, and we are ready for question number 2. So again, everybody here, y'all know the drill. We open it up and cover up all of those answer choices, and then we read the lead-in. So again, here, there's a lot of info, a lot of data that they offer for this one. So let's read that lead-in. Which of the following best explains the persistent reduction in blood pressure at the end of the study? Okay, so here we are. We've got a kind of a research question in here, so we know what it is we're going to be looking at. So let's go ahead and read the vignette. A research study investigates the mechanism by which thiazide diuretics lower blood pressure in patients with essential hypertension. After administration of chlorthalidone to a group of 20 patients who were placed on a low-sodium diet, the following effects are seen. 1. Fall in plasma volume and a concurrent drop in blood pressure. 2. Gradual return of plasma volume to normal. 3. Mean blood pressure is lower than before the drug was given, despite the return of normal plasma volume. And 4. Cardiac output stays at baseline in all subjects. Okay, so again, the question, which of the following best explains the persistent reduction in blood pressure at the end of the study? See if you can start kind of synthesizing and parsing some of this in your head as I pass it on to Abraham.
All right, so this is a different worded kind of question, right? So we're not kind of used to seeing sometimes these kind of lists from 1 to 4 when they talk about research stuff. These always used to throw me off when I study for step 1. Keep it simple. Don't get overly caught in the weeds of the question. Make sure you just focus on what's the most important thing. So let's go through, let's highlight, let's try to really get the core of the question down so we're not getting caught in all the mumbo jumbo. Okay, let's look at the lead in. That's the most important thing. Okay, best place, the persistent reduction in blood pressure. Okay, so what is explaining that why is the blood pressure staying low, persistently low? Okay, so we're looking at mechanisms of thiazides and see how they lower blood pressure. Okay, so they give a bunch of patients chlorthalidone, give them low sodium diet. Sure, that's a study. We don't care about how many people in the study. We don't care about all that stuff. Now, these 4 things are important. Let's go through one by one. So number 1, there is initial volume with a concurrent drop in blood pressure. So they both drop initially. So you got volume going down, blood pressure going down. Number 2, gradual return of plasma volume to normal. Okay, the volume got back up. Then the mean blood pressure, however, stayed lower despite the return of normal volume. Okay, so that's a very important one. Number 3 is important. Number 4, cardiac outputs at baseline. Okay, fine. So you want to use the combination of all this information to really think about what's going on and why that blood pressure is staying down despite the fluid returning to normal in a thiazide diuretic in a low sodium setting in this study. All right, let's look at the options. Let's try to figure out what's going on. Hope we didn't get too lost in the mumbo jumbo there, but that's the key of the question here. All right, let's go through the options here and we'll kind of talk about this. Option choice E is a vasodilation. Option choice D, lower stroke volume. Option choice C, increased renal sodium reabsorption. Option choice B, decreased GFR. Option choice A, arteriolar vasoconstriction. So these are all good options, and some of them might make multiple of them make sense, but only one would really answer this question: why the blood pressure is persistently reduced despite the volume returning to normal. Okay, it's kind of a good factoid question to really learn from, and I think this is the one that I learned from as well. So take your time, go over this question, and let's pick an answer.
Okay, everybody. You heard the doctor here, so go ahead and make your selection. And let's share the results. Okay, so about a third of you, almost a third of you, went with vasodilation, and then kind of a two-way tie for second between lower stroke volume and increased renal sodium reabsorption. Some of you went with decreased glomerular filtration rate, and a few went with arteriolar vasoconstriction. Okay, very interesting. So let's hide the results. And let's show the answer. And the answer is answer choice E, vasodilation. Okay, so once again, you guys did a nice job. Not quite as easy, I guess, as question number one, but nice to see so many of you got that one. But 2/3 of you didn't, so that means we've got some explaining to do. So Abraham, can you walk us through it?
Yeah, great job, guys. Definitely a trickier question than the last one, and requires a little bit more nuanced thinking. Okay, not just clicking the first thing you think about, and especially how the question is worded. You kind of take a little bit of time to decrypt it. Okay, so let's first talk about what are thiazide diuretics. Our thiazide diuretics are diuretics that work in essentially causing sodium diuresis, right? Natriuresis. How it works is it blocks the sodium and chloride co-transporter and the DCT. Okay, that goes back to your early understanding the nephron. And then you end up losing fluid, right? So that's what they're saying. That's what number one is saying. Initial drop in plasma volume and blood pressure. They both go down together. That's the acute setting. Now, eventually, our body gets kind of used to it, and we start compensating for the lost volume. So we start returning back to normal within 4 to 6 weeks. But in the long run, even though the volume is going back up, why is the patient's blood pressure staying down? Well, thiazides have a secondary mechanism of action. So the primary one we know, sodium chloride co-transporter inhibition, therefore we lose fluid. Secondary one, now the exact mechanism is not fully understood, but it has a direct vasodilatory effect on the smooth muscle. So it works on the smooth muscle of the vessels, makes it vasodilate, and causes hypotension or dropping in blood pressure. And that's kind of the secondary mechanism by which it works. And that's important to understand. So it works to not only get rid of the fluid if in a hypervolume state, but also has the vasodilatory properties. And that's what we use it a lot for. Other options here, I know we'll go through like the least one. So A, obviously, if I'm doing arterial vasoconstriction, I'm going to increase blood pressure, not reduce it. So take that out right away. Decreasing GFR. Same thing, right? If I reduced my GFR, wouldn't that increase my blood pressure in terms of holding on to more fluid in my body? Option choice C, increase renal sodium reabsorption. Again, that would maybe explain why the volume come back to normal. But initially, it does the opposite. It makes you pee out more sodium. And that's what the natriuresis part of it is. And increasing renal sodium absorption would increase blood pressure. And then lower stroke volume, again, there's a maintained cardiac output. And that's not the main reason for the drop in blood pressure, right? You're talking about the volume is normal here. So the stroke volume shouldn't be affected. You're worried about the vasodilatory properties of thiazides. And that's the reason for this. So a little bit of a kind of a unique thing. Whenever we learn thiazides, diuretics, we think, okay, This is just making you pee out sodium. But there's a secondary mechanism, which is what steps like the test, like the weird stuff, that the additional things that you need to know. And these are the things that, unless you do questions and kind of run into things like this, you won't really learn that. But I'm glad we were able to cover this one, and good job, guys.
Yeah, nice work, everybody. We're about halfway through it, and hopefully there are some things that you've already written down or committed to memory. A lot of helpful advice here. So it's time for a stretch break. So take a quick little breather. Your GFR might be working overtime, processing all this info. So, one thing I would just want to, touch on, we've at USMLE-Rx, we have a lot of resources available to you, including our RX bricks. So we always like to think of the bricks as, kind of like the proximal tubule of medical education. They reabsorb exactly what you need while letting the low yield stuff get filtered out. Our bricks are great at really breaking down complex topics into digestible and high yield chunks that stick in your memory. And they also adapt to various learning styles, right? Lots of visuals, lots of practice questions. And obviously, USMLE-Rx, our RX 360 Plus platform has bricks. It has our entire QMAX question bank, all 5,000 plus questions in there for step 1 and step 2. Plus, we've got about 14,000 flashcards and 1,300 videos. So there's a lot in there. So, we do have a special offer we'll touch on here at the end of tonight's session. But again, as you're thinking about, hey, what do I need for the home stretch, or what do I need to help prepare myself? We definitely want to make sure that you keep us in mind. Okay. So with that, let's go ahead and get back to tonight's renal adventure. And we'll start here, part 2, with question number 3. Okay. And again, what have we done? Well, we've covered up the answer choices. Now what do? We read the lead-in. Which of the following is the most likely cause of this patient's acute kidney injury? Okay, so again, you're getting a nice mix of questions here tonight. Often in step 1, there's a lot of what's the diagnosis type of questions. So we're mixing it up tonight so that we can get you to kind of think about these things a little bit differently, or at least approach some of these topics from different angles. Okay, the way that you may see them here on test day. So with that, we know what's going on with this patient, at least from a diagnostic standpoint. So now we're going to be trying to figure out what the cause of this AKI. So with that, let's go ahead and read the vignette. A 72-year-old woman hospitalized for osteomyelitis is evaluated on day 4 in the hospital for worsening renal function and low urine output. On day 1, she received vancomycin and ceftriaxone. On day 2, she underwent operative bone debridement, during which her blood pressure dropped to 85/60, and then recovered with the administration of normal saline and vasopressors to normalize. Although her operative site appears normal today, her blood pressure is currently 126/82, and she is afebrile. Serum studies show blood urea nitrogen level of 48 and creatinine of 2.6. Urinalysis shows a urine sodium level of 46, fractional excretion of sodium of 2.1%, and tubular epithelial cells. So again, which of the following is the most likely cause of this patient's acute kidney injury? Start to, formulate possible answers in your head now before you see those answer choices as I pass it over to Abraham.
Thank you, Jeff. Well, we have a little bit more of a sick patient here, right? So there's some pretty big important information buried in this little paragraph here, and that's typical step, right? You're going to have some relevant things in there, some not so relevant things. So your job initially is to read through the lead in and use that to help guide what you want to highlight, what you want to focus on. But a hint that I will always say is, if I'm going back and just reading the highlighted words, I should be able to answer the question. That's how good your highlighting skill should be. You don't need to highlight everything, but at least the most important keywords that kind of paint the picture and helps you understand what's happening. So let's throw some highlights up here and let's try to break down what is the most important stuff in this question. All right, so we're thinking cause for AKI, which is acute kidney injury. So it's just asking you, okay, what's the explanation, right? It's not, is it like a diagnosis? Is it a mechanism? Maybe something along those lines. All right. So let's start from the top. You got 72-year-old woman, classic osteomyelitis, right? So we know there's some kind of infectious process going on, and 4 days in the hospital, and the kidney's been getting worse and worse. Initially, they were started on broad spectrum antibiotics, which is vancomycin, ceftriaxone, and then they had debridement, and then blood pressure dropped to 85/60. That's pretty important. Required fluids, vasopressors, and it's done better. Now it's 126/82. Now, the BUN is 48 with a creatinine of 2.6. And the urine sodium, that's an important number, is 46 with a FeNA, which is a fractional excretion of sodium, of 2.1. And then when you look under the urinalysis, you see tubular epithelial cells. So that last three sentences are very important. Lots of things covered there. And also, you want to understand the what's going on in the concept, like why they're having this in the first place. So putting all of this together, you guys should have a diagnosis in mind. And we should kind of, when we look at the options, one should really stick out to you. If not, that's okay. I still want you to make a guess. I still want you to think about which one makes the most sense in the situation. Part of this is test taking skills, is being able to deduce the right answer, even if you don't know it right away. And that's something that you will learn over time and you will continue to work on all throughout your medical career. So let's look at some options here and let's figure out what the answer is. All right, so we got 5 options again. So we'll start with option E, renal ischemia. Option choice D, post-infectious glomerular nephritis. Option choice C, autoimmune glomerular injury. Option choice B, adverse effect of vancomycin. Option choice A, adverse effect of ceftriaxone. Now, I'm not saying that all of these can't cause some kind of kidney injury, but in this situation, with this story, with this clinical picture, which makes the most sense and which would I hang my hat on as the most likely cause of the patient's acute kidney injury? Very classic question in the hospital. Take your time, look at the options, and let's pick the right answer.
Okay, let's go ahead and launch the poll. And let's share the results. Okay, so for this one, we've got about half of you went with renal ischemia. Almost a quarter of you went with adverse effect of vancomycin, and getting close to 20% with almost 1 out of 5 went with post-infectious glomerulonephritis. But anyway, we've got a pretty strong consensus here behind renal ischemia. So I'm going to hide the results. And let's share the answer. And the answer choice is indeed answer choice E, renal ischemia. Great work, everybody. A lot of information in that particular vignette, a lot of data. So you did a very nice job in kind of sifting and sorting that. So well done. If you didn't get it right, that's okay. Like I said, there are all, a lot of plausible distractors here. So Abraham's going to walk us through it.
All right, great job, guys. Again, this is a tricky one here, but I'm glad you guys caught on. So, and even if you didn't get it right, we're going to talk about this, okay? So there's a couple things that stick out to me right away. So the story, right? So it's an old lady coming in with an infection and her blood pressure tanked. She went 85/60, right? So she was in shock. So that's very important to understand. She required vasopressors, such as norepinephrine, and then fluids. in order to bring her blood pressure back up. So this happened for 4 days. Timeline is also very important, and that'll help to differentiate some of these guys from each other. Because some will take much longer to happen, much will happen much quicker. So you want to kind of understand which window we're kind of sitting in here. Now, and then the most important thing here is the last couple lines, like I said. Understanding how to interpret my creatinine, the UN, my urine sodium, and my phenol. And of course, when they say tubular epithelial cells, that's a big extra clue they're kind of throwing in there as well. So, a couple important things here. So, when I'm seeing, so this phenol is 2.1% with a urine sodium of 46. So, that means that I have a high urine sodium. So, it should be around less than 20 generally, and a high phenol. So, it means that there's a lot of sodium in my urine. That means that my ability to reabsorb my sodium is damaged. So, the problem is there's actual damage to the kidney. This isn't a problem of just, hey, there's like this person is just low on fluids, but this person is low on fluids to the point where they really develop damage to the kidney, and they have these tubular cells sloughing off, forming casts, and ending up into the urine. And this is that classic muddy brown cast that they explain. If you see images, that's what they'll kind of give you here. That's can also pick it. This is ATN, acute tubular necrosis, one of the most high yield diagnoses to be aware of, especially in nephrology when you kind of deal with some type of hypotensive, some type of toxin, or crush injury. There's so many different reasons that can lead to ATM. There's just a big pile of them. But recognizing that in this situation, the patient got hypotensive, developed a renal ischemia because, hey, my blood pressure is low, my organs aren't getting enough blood. I'm not perfusing my organs. So the kidney got hypoperfused. Some of the tissues are dying off, like necrotic. So acute tubular necrosis, the tubules start dying off and falling into the urine. So I get these how they describe it, tubular epithelial cells, or they call it casts, muddy brown casts, or into the urine. And that's important. And that's the underlying issue. But really, a lot of the other ones can also cause AKI. And a lot of the other ones can also cause kidney injury. So why is it not the rest? And that's what really this question comes down to, and being able to differentiate that. Let's start with option choice D. Let's work our way out. Post-infectious glomerulonephritis, right? So we know those. We're talking about typically strep, sometimes staph. And this is like 10 days plus, right? When you think at least 2 weeks generally for these people. These are people that, hey, I had typically like a skin infection or sore throat or some type of infection. And then a couple weeks later, I get dark urine. It's the classic micro question that they give you. That's the post-infectious glomerulonephritis. Takes at least 10 days. This guy's getting it within 4 days, and he had like hypotensive episode. Right? You can argue, oh, he may have staph with the osteomyelitis and that, but it's too quick. That wouldn't be the reason, right? Because you're thinking more of a hypersensitivity reaction as opposed to depositing it. So it's not the same thing. Let's go to the next one. Autoimmune glomerular injury. Well, autoimmune, you want to be thinking a little different, right? It's not going to be like infection related, unless you're trying to go for like IgA nephropathy picture, maybe that happens within 1 to 2 days of a viral infection. And again, you would generally have a hematuria, proteinuria, not really this typical picture, and they wouldn't kind of give you the tubular epithelial cells in the urine and this story of this hypotension and this guy getting really sick or this woman getting really sick. Next option, adverse event of vancomycin. A lot of you guys picked up, and I think that's a fair thought. We always say, hey, vanc is not nice on the kidneys. Generally, this will take more than just a couple of days of vanc, right? This is day 4 that they're noticing all of this happening. They just received vancomycin on day 1 and then have the procedure done. So it's not a prolonged. So when they say vancomycin causing an injury, think about more than weeks, more than like 1 to 2 weeks of vancomycin chronically. That's when I see the kidney injury. And that's usually in very sick patients. Although she was sick in the beginning, bounced back pretty quickly. Blood pressure is 126/82, doing well. Sounds like she's improving, but her kidneys are not fully getting better because she had that initial insult from that hypotensive episode that leading to that renal ischemia. So option choice B is a good thought. A lot of you guys picked that one, but it takes longer than that for the vancomycin to hurt the kidneys. And option choice A, ceftriaxone. Ceftriaxone can also hurt kidneys, but in a different mechanism. This is called acute interstitial nephritis, AIN, not AT. Different whole beast of a problem, but this is more of presents with rash, fever, and then the way they'll describe is urine leukocytes or eosinophils. That's going to be the typical story. So rash, fever, urine eosinophils. That's going to be your story for ceftriaxone-induced AIM. Different picture, not what's going on. So great job, guys, if you got this one. If you didn't, don't worry about it. The main important thing to understand is that whenever someone has a hypotensive shock episode, in a couple of days, you can expect their kidney numbers to start jumping because they had that renal ischemia and they live up at ATM. You just got to support them through this time, and their kidneys will eventually heal with the hopes that it doesn't progress into CKD or ESRD. But great job.
Okay, this is great. And again, that throughout that explanation that Abraham so kindly provided, there's a lot there. Hopefully, you'll be prepared for this type of question when you see it again. And these are questions that you're going to see, different variations on this particular theme, especially when you're talking about AKI. So let's go ahead and we're going to head to our final question of the night, question 4. Again, we'll have a raffle at the end. We'll have a special offer. So you do need to be here in order to win. So let's go ahead and get it started. A little shorter than the previous questions. So again, we've got the answer choices covered up, and we're going to read the lead-in. Which of the following is the most likely cause of the patient's rising serum creatinine? Okay, so we got another kind of monitoring a particular lab, as well as a most likely formulation. So let's go ahead and read the vignette. A 59-year-old man hospitalized with advanced cirrhosis and ascites undergoes a large volume paracentesis for symptomatic relief of ascites. 3 days later, he has a decreased urine output. His urinalysis and renal ultrasonography are normal. His urine sodium is 12, and serum creatinine has increased from 1.2 to 3.0. Administration of 2 liters of normal saline does not change the serum creatinine. So again, which of the following is the most likely cause of the patient's rising serum creatinine? Think about that. Think about this particular patient. What you think might be causing it as I pass it over to Abraham.
All right, so different style question here, and you kind of think about multi-organs affecting here, right? So talking about a cirrhotic patient. So we'll go through and we'll highlight some keywords here, but I think the way you approach this question is going to be similar to how you approach the other one in terms of understanding the story, understanding what was the insult, and understanding how we interpret these lab values, especially urine studies, right? When we know kidneys love the urine, or nephrologists love to look at the urine studies, and you want to be able to really good at interpreting them. Even though you're not going to be a nephrologist when you're at your step 1, but you want to be good enough to be able to interpret your most common conditions, be able to understand, what is the underlying issue, and just give a general idea. So let's go through it. Let's have the highlights here. So cause of the patient's rising serum creatinine. So same kind of question as the last one. It's like, hey, what's causing the AKI, or what's causing the acute kidney injury? You got a 59-year-old man with advanced cirrhosis and ascites. Okay, so you got to start thinking about that. So what are some associations with ascites? Has large volume paracentesis. Okay, so they took a lot of fluid from the patient's belly just to make him feel better. And 3 days later, he starts peeing. His decreased urine output, right? So that's a problem. They look at, kidneys on ultrasound, all good, and they give you an interpretation of his urine. So urine sodium is 12, so it's less than 20. It was creatinine jumped from 1.2 to 3. That's a big deal. And you gave him 2 liters, because, what do we do normally when we see acute kidney injury? We start giving fluids. Well, they gave him 2 liters. It did not improve. So what would explain why his creatinine continues to rise, and why he didn't respond to fluids? All right, let's look at the options here, and let's try to get a better understanding. All right, so we have option choice E, splanchnic arterial vasodilation. Option choice D, necrotizing inflammation of the renal arteries. Option choice C, necrosis of the tubular cells, renal tubular cells, sorry. Option choice B, intravascular volume depletion. Option choice A, glomerular subepithelial immune deposits. So you got some buzzwords here that they kind of throw around, the classic kind of first aid words that we kind of see all the time. So you want to be able to interpret this and be able to know what they're talking about and what makes the most sense in this setting. Take your time, understand the patient's background, understand why the fluid didn't work on them and why the patient's creatinine rise. So take your time and let's go through the answer here.
Okay, everybody. So again, which of the following is the most likely cause of the patient's rising serum creatinine? Got all of your answer choices there. So let's see if we can put it all together here for the final question of the night. See if there's an answer choice that mirrors that. Okay, let's see. Over 80% of you have voted. So let's close that poll and share the results. Okay. So a little over a third of you went with intravascular volume depletion, answer choice B. A little over a quarter of you went with necrosis of renal tubular cells. And then just under a quarter of you went with the splanchnic arterial vasodilation. It's a difficult one to pronounce. Okay, very good. So let's go ahead and hide the results and reveal the answer. And the answer is answer choice E, splanchnic arterial vasodilation. Let me just say, this is maybe our 175th question lab. I had it up here a little while ago. I shouldn't have closed that tab. But I think this is the first time ever where we've had the same answer choice as the correct answer every time. So it was E across the board all night tonight. So anyway, great job for those of you who got this one right. This was a tricky one. We knew that going in. So I'm going to hand it over to Abraham so that he can walk you through it.
All right. We'd like to end on a tough one here, so don't feel bad. This is definitely a tricky question. This is one that is going to kind of get you that extra, bonus points to get you in the 99th percentile for your step score. So let's talk about something like this and let's try to figure out what's going on. Let's try to understand this first of all, because this is the concept you do need to know. This is something that will still show up again and again. So first of all, what is going on? So when I see someone with bad cirrhosis getting ascites and then having this kind of kidney injury, especially after a paracentesis, you got to think about something called hepatorenal syndrome, right? The name gives it away. Liver kidney syndrome, hepatorenal syndrome. So you have to understand, what is that? How can I explain it? And why is E the answer? So what is hepatorenal syndrome? This is a kind of a really deep, complex topic, and it gets very intense when you start talking to nephrologists about it. But for our level, for USMLE level, there's one thing you guys need to know, that when you have hepatorenal syndrome, or you have some kind of really bad cirrhosis, we have what's called splanchnic vasodilation. So we got a bunch of vessels in our belly, okay? And those are the splanchnic vessels. And those will just vasodilate because our liver is not working, okay? There's a mechanism by which nitric oxide gets involved, and you don't need to worry about too much about all those things. But the idea is that you end up accumulating too much nitric oxide in your body, and then you end up causing vasodilation of all these vessels in my belly. Now, if I have a bunch of vessels dilated in my belly, well, that's going to shunt a lot of the fluid that should go to the kidney into the belly. And that's why you just get these like extra fluid buildup around the belly, and that worsens my ascites and kind of leads to continuous fluid buildup in the belly. So this guy had ascites. You took out a bunch of the fluid, so now there's a negative space there. So all that fluid you took out, your blood, the patient's blood is starting to pull back into the belly and trying to fill up that middle area that is dilated because of the liver failure. That can then cause ischemia to the kidney and lead to, same idea, you can lead to hepatorenal syndrome. It's a rapid onset kidney injury without evidence of actual tubular necrosis or renal ischemia. Right? How do I know this patient does not have tubular necrosis or renal ischemia? Well, look at the sodium, right? If there is tubular necrosis or renal ischemia, like ATN, like my last question, I would not be able to keep my sodium, right? This patient, then you would have a sodium loss in the urine. Remember, sodium is precious to humans. our kidneys are always trying to hold on to as much sodium as possible. So whenever I have some kind of kidney injury, that's when I'm going to see sodium leak out into the urine. This guy's sodium in the urine is low. So it means that the problem is I have like the kidneys getting affected, but there's no necrosis or ischemia or ATN going on. I'm just having direct hepatorenal syndrome going on. Okay, so let's look at why the other options aren't right. And a lot of you guys picked option choice B, intravascular volume depletion. The main reason that I'm going to go against that, they give him 2 liters, not just 1 liter, 2 liters of fluid, then didn't even bump it. If this is a pure volume issue, you should see improvement with volume, with fluids, right? So I'm giving intravascular volume. That would say it should improve it, right? Yes, sure. You can say, hey, there is some level of intravascular volume loss because I'm losing protein and things end up in the extravascular space. Sure. But really, that's not the primary problem here. The problem here that's driving it, right? It's as in cause of the renal ischemia. It's not, you're not just dehydrated because you gave him 2 liters and didn't respond. The problem, although there is probably some level of volume depletion, the problem is splanchnic arterial vasodilation. Cirrhosis leads to splenic arterial vasodilation, which is hepatorenal syndrome, leads to kidney injury. This is not going to lead to ATN, so my sodium is still going to be low in the urine, but I'm going to get this rapid onset kidney injury that occurs. Very high yield, kind of important to understand, especially when you start getting to step 2 and step 3, this comes up a lot more. So if you learn it now really well, you'll probably get maybe a question on step 1, but this will really pop up more in your step 2 and 3 because it's very clinical and this does make sense a lot when you start understanding things at a deeper level. Other options, again, you guys picked, what was it? Let's see, you guys picked necrosis renal tubular cells. Again, like I said, there's no sodium loss. That wouldn't be the answer. And then option choice A and D, necrotizing and subepithelial deposits. We're not talking about those in this situation. Those aren't like notable findings in this. But good job, guys. Knowing cirrhosis, knowing multi-system conditions are very important for STEM. They love things that affect more than one organ system. Okay? Great job, guys.
Okay, nice work, everybody. A lot of great questions tonight, and I think we could probably do renal every week, and there's stuff that we could learn. So nice work. What I've done here, I've in the chat, I've put a link to tonight's test, so you can either go there or you can screenshot this and just enter the QIDs into USMLE-Rx. Again, Abraham always does a great job of explaining kind of that stepwise approach towards reaching an answer. But again, for any of these questions, it's nice to be able to go in there and see, hey, how is this covered? In the bricks. Is there a video for it? Are there flashcards? Tell me more, so that I can make sure that I get it right on test day. So again, go ahead and capture all of that.